And so we're welcoming Dr. Bazhenova back as well. So Dr. Iyengar, one question for you. So I noticed in that trial that you had mentioned closed premature, didn't meet the endpoint that you wanted early. 0 to 3 sites were defined as oligometastatic disease. Do we have a consensus? Is there a site that you would not consider in the context of oligometastatic disease? Is there a number of tumors that is like far exceeds in the absence of having those sharper tools with AI and other things?
Yeah, I mean, I think unfortunately, it was something I didn't point out, but in that slide with all the phase 2 studies, every single one used a numerical value for deciding what is oligometastatic. And numerical values are, unfortunately garbage, because what they represent is one snapshot in time, one cross-sectional snapshot of where the patient's disease trajectory is at. And we have no idea whether they're the low part of the curve, the high part of the curve, they've plateaued out. So as you said, in the absence of better predictive models, we've as a field focused on 5 or fewer Mets to be oligometastatic. But there are studies out from Canada and other institutions in the United States where they're trying to push the envelope and say, in patients with 5 or 10 Mets, can we safely deliver SBRT? And if so, can we identify those patients that I was describing earlier that may have a large number of Mets, but that's because they plateaued out. And if we can safely treat them, they may actually have a benefit. And so, unfortunately, we're stuck with this numerical association right now, but hopefully in the future, we'll be able to change that.
And is the definition of what is an oligometastatic lesion constrained by SBRT feasibility or hypofractionation?
No, it's usually not. And to your other question, I'm sorry I didn't answer it. Whether it goes to the liver, bones, kidney, adrenal, contralateral lung, nodes, there's really no specific definition that we stay away from with respect to oligometastatic. The one thing that is important is that most data suggests that if you need to treat the primary lung cancer, the primary site of disease and the associated locally advanced nodal disease, if there is any, because if you don't treat that and you just treat the Mets, it's of no value.